Dear viewers, welcome you all to our show, OSA, that is Orthopedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance with each other. Dear viewers, today our topic is Ilizarov effect in orthoplasty. That means the combined treatment of post-burn contracture of the toes. And the presenter is the very magnificent and learned presenter, Professor Novikov sir from Kurgan Institute of Russia. I would like to request Professor Novikov sir to join with us. And we have learned academic panel with us. One of them is Professor Mofakharul Bari sir. I would like to request Professor Mofakharul Bari sir to join with us. And another one is Dr. Shamsul Huda sir from Patna, India. And the other one is Dr. Chunu sir from Mauritius. I would like to request all of them to join with us. Bari
Hello,
sir,
good
would you
afternoon.
please? Yeah, good afternoon, Dr. Shamsulullah sir. Professor Bari sir, Mofakharul Bari sir, would you please join with us? Dear viewers, today our topic is a little bit different. That is the Ilizarov effect in orthoplasty. How it is possible? Is it absolutely possible or not? Definitely, we are going to know these things after the magnificent presentation by our honorable speaker, Professor Novikov sir. Now, I'd like to request Professor Novikov sir to start his presentation.
Thank you very much. Good afternoon, all of colleagues. And today I want to introduce some interesting experience in our department when we start collaborate absolutely different surgeon, Ilizarov, orthopedic surgeon, and plastic surgeon. And I want to congratulate all of us with the century since Ilizarov was 70 years of Ilizarov methods and 50 years Kurgan Ilizarov Center. Near 40 years I work in this clinic, and I am happy because more than 9 years I work shoulder to shoulder with this great person. And methods of treatment by Ilizarov of contracture of toes. Maybe these methods will come in our practice because this is little bit rare surgery. Presently, we do not have one single method to treat toe contracture because problem is to return to the corrected position of the toes after surgery. And post-burn deformity is a severe complications of thermal injury to the foot. Foot burn contracture are specific by their topographic location, the extent and severity of the burn wound and scars that can develop on the dorsal, volar, interdigital aspects of the foot, causing flexions and adductions contracture of the entire foot, flexion and extensions contracture of toes, shortening of the Achilles tendon, plantar aponeurosis, etc. Scars deformity of the foot are reported to range between 5 to 7 in adults and in 10% of all bone deformities of the localization in children. The dorsum of the foot and toes are involved in more than 80 of the cases. Anatomically, the dorsal aspect of the foot is characterized by the proximity of the ligamentous, articular, vascular, and nerve structure of the foot and skin. Epidermis protecting the Malpighian layer of the skin from the environment measure 0.1 to 1 millimeters. The ligaments of tendon around the dorsum of the foot and the ankle are covered by thin skin, being nearly void of subcutaneous fat. Deep dorsal burns of the foot result from minor exposure to an external heat sources involving many anatomical structure into a pathological process that lead to clinical and functional deformities of the segment. Burn deformities in the dorsum of the foot can be caused by both the cutaneous injury followed by scarring and the secondary involvement of underlying tissue into the scarring and changes in the ligaments articular structure. The pathological scars lead to cutaneous scars contractures in conjunction with autogenic dysfunction. Thick root measure scars develop on the dorsum of the foot, being susceptible to recurrent trauma from use of road footwear and can result in hyperkeratosis or ulceration adhesions of skin to underlying tissue. The factors can lead to eliminated plantar flexions of the foot, subflexions and dislocations in the digital joint, reduction clinical and functional capacity of the segment, and causing major cosmetic problems, inability to wear normal footwear with resultant impaired quality of the life and physical rule limitation. Scars bands run over the dorsum of the foot either as a solid entity or reach each of the toes in the fan-like manner, causing overextension of the metatarsal phalangeal joint. Neglected deformities in pediatric populations can result in secondary foot deformities, dilated growing and bone malignment. The patient retains full range of motion in the joint of the foot and toys then facilitates favorable outcome of the real-time surgical treatment. Burn wounds may heal with keloid scars due to specific anatomy and physiology of the foot. Keloids may appear even the relatively superficial burn and can develop into callosity and ulceration, being susceptible to the recurrent trauma. Extensive persistent trophic ulcers that fail to resolve spontaneously can be closed with different flap design of skin plasties. It is essential to select an appropriate technique for foot reconstructive surgery in severe deformity of the segment depending on location and extension of the involved area. Treated options included skin grafts, local flap, and free flaps. Extensive soft tissue release and complete resection required for reconstruction of a severe foot deformity. However, skin grafts and local flap provide limited soft tissue coverage, making reconstruction surgery difficult in many cases. The known treatment options for severe bone contracture and deformities of the dorsum of the foot include skin plasty with the Filatov tube pedicle for adequate skin coverage of the defect, followed by the hinged distraction fixation system. Patients who experience total and subtotal burns have shortage of donor tissue availability in the technique cannot be applied for them. In our options, the below techniques can be the methods of the choice of such cases. The surgical interventional includes excisions of cause scars of the dorsal aspects of toes and both feet, autologous full thickness skin grafting of cutaneous defect combined with plasty and interdigital web space and toys. In Ilizarov, external fixator was applied to create conditions for gradual longitudinal tractions of problematic toys, distensible corrections of the deformity, and subluxations in the metatarsal phalangeal joints. Ilizarov mini fixator was attached atypically to the plantar aspects of the foot only to leave the dorsum free from metal constructs to easy dressing and manipulations with autologous full thickness skin grafts. The so-called wire and wired tractions or threaded soft tissue structure fusion toys to the plantar surface of the foot were traditionally used by surgeons to extend and hold two toes in the relating position. The method was often associated with bedsores development in the 9 bearing toys due to the pressure from the needle, spill, or cutting through the soft tissue. The techniques we offered included the use of fine 1 mm wires placed in digital phalanges in the coronal plate at the same level and curved in a special manner. Symmetrical double bending was produced for the phalangeal wire driving in the frontal plane. The wire was first bent on both sides of the toy, 1 mm of the skin at 90 degrees in vertical plane, and then it was bent at the same 90 degrees in the sagittal plane, 3-4 mm of the first bending. The wires were framed being the nail plane with free ends locked or looped. Оля, я читаю, я перезвоню потом. A longer free end of the wire was fixed to remove nodule with the possibility of producing gradual distensible traction, allow the axis with the toys not touching each other and the metal contract components. The distensible tractions was provided with wire elasticity and bendings. The techniques allow for corrections of severe combined bone deformity of the foot and toes, consistently maintain the intraoperative result and providing and easy absorbing retention of grafting tissue, change in dressing and patient's mobility. The above approach can be illustrated with a clinical instance. A 9-year-old girl sustained a boiled water burn a year before admission. She used natural home remedy for 5 months. The wounds healed with the cause scars, and the patient developed a severe burn scars deformity of the feet and disturbing gait. Yeah. This before treatment, patient cannot use normal shoes, cannot normally walk. Severe contracture, we can say subluxation, full luxation, certain force array. And physical examination of the patients revealed causes hypertrophic scars on the dorsum at the feet and the lateral surface of the tibia. Start plastic surgeon, remove severe keloid scars, then take free flap from body. Then we apply, this is funny, Ilizarov but magic support. Operative interventions were performed consistently of both feet. First on the left side, and then a similar procedure was produced on the right side after the frame had been removed from the left foot. Tourniquet was applied intraoperatively to the mid-third of the femur, and the scars were exist on the dorsum of the left foot on the base of toes. Hemostasis was produced and edges of the wound mobilized. The cutaneous defect was partially repaired using the upper used cut of triangular flap that were fixed with interrupted Donati stitches after the transfer, and Prolen 5.0 suture were applied to the skin. The toe were straightened and attempts were made to bring the third, fourth, and fifth toes to flexions, but failed due to rigid and U-shaped flap with the base to the plantum were cut off the second, third, and fourth interdigital web space. The flap were advanced and fixed on the dorsum on the foot at the level of metatarsal phalangeal joints. Full thickness skin was harvested from the right side, growing area to cover the defect of the foot. Donor wound in the right iliac area was sutured layer after layer with interrupted Donati stitches. Recryl 4.0 sutures were used for the subcutaneous tissue, and Prolen 5.0 sutures were applied to the skin. The graft was treated with the Krasavitov technique and placed at the subcutaneous defect site of the foot and sutured in the perimeter with interrupted stitches. Aseptic dressing with traumatic mesh gauze was applied to the wound. Overall operating time with use to the tourniquet was near 1 hour, 50 minutes. We applied to the plantar aspect for the plastic surgeon to the work. Gradual traction was provided for 10 postoperative days for stretching and reducing subluxation in the third, fourth, and fifth metatarsal phalangeal joints to bring toes to the flexions. It was comfortable enough for the patient due to the minimum forces developed by the frame and aimed to address the articular component of the contracture. Full thickness skin graft appeared to stretch easily and pain-free to toe tractions, getting the toes to flex. The toes were should to get flexed and the frame was transferred to the fixation mode for 3 weeks to follow full integration of autologous skin graft into the wound bin and was taken at the same time with sutural removal. The patient received antibiotics, medications to improve microcirculations and relegation blood properties. And we not remove stitch in our dressing room. When was second surgery, we remove these stitches. And after similar surgical was produced for the right foot after the frame had been removed from the left side. Nothing the bilateral foot deformities could be visualized radiological and 2.5 months follow-up. The patient underwent complete rehabilitation for another month. This is before treatment. Therefore, the above clinical study was shown that a severe burn foot deformity can be treated within one surgical section using combined skin plasty and the Ilizarov external fixation, addressing subluxated toes, subductively scars, and the dorsum of the foot, etc. To facilitate good clinical and functional outcomes, foot growing and development in pediatric population. However, further improvement of the technique is needed to include classifications, algorithm of examinations, and selections of the treatment strategy depending on individual characterization of anatomical and functional impairment of the foot. This would allow the wider applications of the technique at different levels of health care system. Before and photograph of follow limb at the 2 years after surgery. I think just now this is a young girl and her parents is more than happy. Before treatment and when same situation without Ilizarov orthopedic surgeon start treat plastic surgeon, they have a result, but not so good. When we start support this patient without plastic surgeon, already we have some results, but not so good. But when we collaborate, we have result like that. I can say this is amazing, fantastic result for me and for plastic surgeon. And next slides, I want again talk about our father, about subjective and objective, and Ilizarov give us freedom, give us possibilities, give us future, and give possibilities connect with so many doctors and see what say surgeon from Islamic country about Ilizarov methods. Congratulate all of us with genius, with methods. This is plastic surgeon. This is another plastic surgeon, Mr. Korostolov and Mrs. Shikhaleva, great surgeon. And when we collaborate with so many different, not only toes contracture, and for example, knee contracture, elbow contracture, when we work together, result is magic. Thank you very much for your attention, for your time, and I hope in the future we can find another place, another area when we can use this is fantastic effect of Ilizarov. Thank you very much.
Thank you very much, sir, for your excellent presentation. That was a magical presentation. Now, I would like to request Professor Mofakrul Bari sir to share his experience. Before that, I would like to welcome Professor Indranath Chunu sir, because of he joined with us in the mid part of the presentation. Sir, welcome to our show, Orthopaedic Solution.
Chunno. Now our great Chunno is.
Yeah, now I would like to request Professor Mofakrul Bari sir. Sir, do you have any experience regarding the correction of post-burn contracture? As I know, you have done this. So please, would you please share your valuable experience with us?
First of all the panelists and the speaker, Professor Novikov, he nicely elaborated everything regarding the post-burn contracture and the treatment. And here, you know, we are getting also a lot of cases in our country, and we have a burn institute, 500-bedded hospital in Dhaka, and as well as in the Dhaka Medical College. We have a special 500 burn unit center in Dhaka, and a lot of cases, the post-burn contractures that is treated by Ilizarov. And Professor Novikov nicely showed especially the deformed cases after the burn, in case of the phalanges and in between the he elaborated everything by using the simple 1 mm K-wire. And he has taken the help of Professor Shikilova and Karastova there. I was there in their unit. It's a very good unit, fantastic. They are doing combinedly with the Ilizarov as well as the plastic surgery. So it gives a very good result. Regarding this, and he has showed nicely the before surgery and after the surgery a long-term follow-up. One thing that I could not understand, that one, he mentioned Krasovitov technique. Can you tell me that is in Kurgan Center technique? Can you tell how you applied that one? Technika Krasovitova.
Professor Novikov sir, can you hear us? I think there is some network problem is there. Uh, Professor Navikam sir, can you hear us? We cannot hear you properly, and I think your network is disturbing there. Anyway, Professor Mafakarul Bari sir,
Good
Professor
case,
Navikam sir,
fantastic case. Because again, if you think about the principle of Ilizarov, again, law of tension and stress, that and dislocation. You can go for gradually by differential distraction. You can cover the deformity, contracture, as well as the subluxation and the dislocation cases. And Professor Novikov nicely demonstrated the cases. These are the difficult cases without Ilizarov on the deformity and as well as the subluxation and the dislocation. And with Ilizarov, mini Ilizarov fixator with bows, small bows, you can gradually, when you will apply the Ilizarov law, that is slow and steady traction on a living tissue creates a stress which is metabolically activated and which stimulates histoneogenesis, genesis, distraction osteogenesis. And thank you very much, Professor Novikov. So I'd like to only know that one, Krasovitov technique, if you can describe me that one. Can you listen to me, Professor Novikov?
Professor Navikam sir, can you hear us, sir? I think Professor Navikam sir can't hear us.
Yeah, I think he has network issues.
Yeah, he has network issues there. Okay, I would like to request Dr. Shamsuluddin sir, do you have anything to share with us regarding the topic, the post-bond contracture
Yeah,
or like that?
yeah. Thank you, Dr. Tanvir. I have a short experience in doing lengthening of toes in post-bond contracture cases, especially in pediatric and adult cases both, not deformities. So I have done this shortening of toes in foot with small distractors, not with Ilizarov. And that works very well. Few of the cases I've got pediatric cases, few are a young lady who could not marry because of this. So it works very well with these cases.
Okay, that's great. That's great. But how long it takes to recover?
Around I think 3 months approximate is fine, because the lengthening toe lengthening is there in around 2 to 3 weeks. Is fine, and then we leave the distractor as such to regenerate, and around 8 weeks or 12 weeks it consolidates well. So in 3 months you can easily remove that.
Okay, that's great. Can you use that destructor in any other part of the body?
Yes, the distractors can be used in hand, the fingers. You can use like here in the metacarpals, the phalanges as well. And few of the I have seen few of this maxillofacial surgeons, they have been using in this mandible lengthening also.
Yeah, yeah, definitely. Yeah, that's a great thing. Hope we will see in the coming part of
Yeah,
our program from Dr. Shamsuluddin sir, like this type of presentation,
yeah, sure.
lengthening by a small distractor. We are waiting for that. Now, I would like to request Dr. Chunu sir. Sir, do you want to contribute something regarding our topic? First, you have to, sir, unmute yourself. Please unmute yourself. We can't hear you, Professor Chunu sir. Please unmute yourself.
Sir, please unmute, sir.
Sir, please unmute yourself. It is below your screen, sir. The lower part of your screen. Professor Chunu sir, we can't hear you, sir. Please unmute yourself.
Can you give him a WhatsApp call? It's not listening.
Yeah, I think so. No, sir, we can't hear you, sir. Professor Chunu sir, we can't hear you. I think we're facing networking problem here. Most of the panelists are facing the network problem. The dear viewers, today we're discussing about the topic that is the Ilizarov effect in orthoplasty. Sometimes we use the combined treatment effect in case of post-burn contracture. We can use a team for plastic surgeon as well as the Ilizarov surgeon, both to help the patient to recover from this type of contracture. And in Bangladesh, we are also doing the Ilizarov in case of post-burn contracture. We have lots of case history there. Especially our Professor M Bari sir did these things. A lot of cases are there, and I hope we will discuss these things. We will take this sort of presentation once more to you in the coming part of our program. And you also came to know that we can make the lengthening also by the small distractor, as Dr. Shamsuddin sir says, and we are hoping and that Dr. Shamsuddin sir will present this type of presentation in the coming part of our program, and we are eagerly waiting for that type of presentation. And today, as because of we're facing some sort of networking problem, so I would like to end up our program now, and I would like to thank everyone who were with us, especially I would like to thank Professor Novikov sir for his excellent presentation. And I would like to thank Professor Chunu sir for joining with us, though we are facing some sort of networking problem so that we can't hear him. But hope we'll recover these things in the coming part of our program. And I would like to thank Professor Mofakarul Bari sir, and a special thanks to Dr. Shamsuddin sir. And I am Dr. Mohammad Tanvir Ashraf saying bye-bye to you. And definitely I would like to thank Raj TV and Renata Pharmaceuticals Limited for being with us. Dear viewers, so stay with us and stay with Orthopaedic Solution Academy to take the Ilizarov magical information. And I would like to say bye-bye to everyone. Bye-bye.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe our channel.